don't know if I can say anything after such an extensive and fabulous talk. Rima, your talk is absolutely, I should commend your talk because you were so complete, but we could debate. So I don't want to polarize the conversation, but when we talk about, with Seth about what kind of talk we should give, we realized that there was a publication that just came out that was polarizing our colleagues in radiation, well, in surgery and medical oncologists. And I think that what I aim in this talk is to give you some arguments and some bullets, because you all face those questions. And I think it's very useful that we know what to answer, and we have a common voice as radiation oncology and as Maestro for this. So the question note is about exactly what you were saying, the omission of radiotherapy for early stage breast cancer. Not typical in the Middle East, but we sometimes have those patients. So, like you said, omission of radiation for early stage breast cancer, long story. I recall in the 1999 publication, JCO by Liljegren. It's a Swedish study. I see my friend nodding. Diagnostic through mammogram. Oh, those are T0 cancer, and they are so early stage. Do we still need radiation? And then, okay, 381 women randomized, surgery alone, surgery plus radiation, local recurrence rate at 5 years, 2.3% with breast conserving and radiation, 18% radiation essential. Then my friend Tony File at PMH did this study, more and more women as tamoxifen. So does the tamoxifen was an impact on local recurrence? When women have the breast conserving surgery and tamoxifen, do we need the radiation? And he selected really the low stage, like, the stage 1, stage 2 patient. And the local recurrence rate at 5 years was 7.7% versus 0.6%. But if you dig in the article, you will find that at 8 years, it's 17.6% versus 3.5%. They did a post-hoc analysis, unplanned analysis, and find that for a highly selected group of patients, no more than 1 centimeter, hormone receptor positive, above a certain age, maybe we could, but it's a post-hoc analysis, maybe we could omit radiation. And in the same issue of the New England Journal of Medicine, with a publication from Boston, our friend Youth, who selected the patient over 70 years old, breast conserving surgery and TAM, with or without radiation. And because he selected so well the patient, local recurrence rate was 4% versus 1%. Fair enough. NCCN guideline, everybody reflect on the NCCN guideline. For those very early stage and 0, hormone receptor positive, after breast conserving surgery and negative lymph node, you can offer whole breast radiotherapy plus or less boost, if you have LVI, close margin, everything, or consider partial breast, exactly what you said, Ray, or consider omitting radiation for the patient who receive endocrine therapy. That's a guideline. So our friend Tim Whelan said, let's confirm those data, because most of those data are based on post-hoc analysis. They are not very firm. And I recall when he developed the luminal trial, I was still at Sunnybrook, and he said, I would like to retarget the woman, post-menopause woman with an IDC that are luminal A. And he defined the luminal A as ER positive, PR positive, 1%, 20%, and HER2 negative, of course. And for him, the K67 should be less than 13%. Clear margin, breast conserving surgery, and patient receiving 5 years of tamoxifen. And because if you want to do a non-inferior study, you would need thousands of patients, he decided to do a single-arm study, radiotherapy omission at 5 years. And his hypothesis was to say, assume the local recurrence should be around 3.5% at 5 years, and less than 5% is acceptable. So you have a threshold, you have a thing, you can calculate a standard deviation. And so the two-sided 90% confidence interval, meaning 5% on each side, you just need 500 patients. So study published this summer. And this summer, he found that the local recurrence rate at 5 years is 2.3%. And the confidence interval cannot reach the 5%. So he concluded it's a very good study published in the New England Journal of Medicine. You can see here that the age, you have 60% of the patients that are above 65 years old. Small size, half of the patient has less than 1 centimeter. and 2/3 of the patients were grade 1. So really highly selected patient for this study. And we have some other studies. So the conclusion of the Riyadh trial, and I'm reading the two last sentence of the conclusion, is our study showed that women above 55 years old, T1 and 0, grade 1, 2, liminal A, had a very low recurrence rate at 5 years after breast conserving surgery when treated with endocrine therapy alone. Can't agree more. The prospective and controlled nature of these studies support our conclusion that such patients are candidates for omission of radiotherapy. Oh, wait a minute. That's something I cannot reconcile here. I cannot reconcile the controlled nature and the real world. Because controlled nature meaning that you're sure your patients, are controlled. You have absolute control. And that's something in the real world that is published, highly published. You have tons of publication and a great review done by Murphy, published in the Breast Cancer Research and Treatment. In that in the real world, patients often, they don't follow the tamoxifen. You can see that when you do a review, adherence, meaning, did I get the right amount of tamoxifen? Well, range from 40, meaning between 1/3 and 2/3 of the patient don't take the tamoxifen that you prescribe. But wait a minute, you have between 30 to 70%, between 1/3 and 3/4 of the patient just stop tamoxifen because of side effects. So the control nature doesn't mean that this is what you should do for patients, and that's a word of caution. So what is the real world? Well, in 2020, when I was in Halifax, we look at those data to see really what the real world. And so we went to the Nova Scotia Cancer Registry, and we identified about 3,000 patients that were 70 years old or more. And although digging in the number, we came to a cohort of 460 patients that were T1 and 0, negative margin, no chemotherapy, and we have reliable information about radiation, endocrine therapy, one, the other, or both. And those are our data. The local recurrence rate at 5 years, very low when you take both, like less than 1%. 1.5% with radiotherapy, 4.2% with tamoxifen. Oh, meaning those patients don't, clearly, it's not the 2%, it's double. And if you have no treatment, it's 12%. And you can see that if you go to the 10 years or the 15 years, we go to the 17% that was found by you. So our data are very consistent with everything. So what would that mean in terms of survival? Well, in the real world, there is another study that was published this summer that I found fascinating, a study from Toronto. SOPIC, which is part of I don't recall the name, but it's one of these epidemiology, which is phenomenal in Toronto. He looked at all patients treated in Ontario from 1987 and 2000 and found that on the early stage, 14% have a local recurrence rate. It's about 260 patients. And out of those 260 patients, when you have a local recurrence, 30% of those patients will die because of the recurrence. And so if we take the Whelan data, like you only have 2.3% recurrence and you assume it will be a plateau, then 0.6% will die, probably negligible. If you take our data, 10 years, 1.7% will die. But if you take even more patients not taking any tamoxifen, you will find that close to 4% will die. So just to compare this number with another one, when we do mammography and we pose a very painful exam to women after 50 years old every 2 years, and we stress them a lot, and we do a lot of biopsy for nothing, 80% of the biopsy go to nothing, is for a benefit of mortality reduction of 0.21%. Of course, absolute number are very big because that's a whole population versus the population of patients that have with breast cancer. But if you are able to do some constant follow-up for women for this benefit, then we better to call back all our patients that we discharge and redo long-term follow-up. So that's a consequence of saying, oh, I'm okay not to treat my patients. And the other word of caution is exactly what you were saying, Ray. What kind of radiation are we talking about? Because, when I talk to my medical oncologist, they say, to prevent local recurrence, I'm going to prescribe tamoxifen so they don't need the radiation. They don't need the burn of radiation. Well, wait a minute. Those patients are eligible for the fast-forward trial, which is only 5 fraction, 26 green 5 fraction. And just as a reminder, the fast-forward at 5 years has 1.4% local recurrence rate. and there's no burning, there's no side effect. It's just 1 week and treatment and go very fast. 1 week, but when I was at Sunnybrook, we also do a single day procedure. I was very jealous because my friend doing GU, they get a prostate patient, 1 day procedure, go home, forget you had a cancer. And I had my patient treated 5 weeks for breast cancer. So we say, why don't we do that for breast? They say, you're crazy. Crazy, meaning there's a research idea here. So we developed these techniques where you do a local freezing, light sedation, and you place a needle that is grooved, you hook the surgical cavity, you place a template, you place exactly what my colleagues were doing for GU, meaning you have some loaded stranded seeds, and you read them, and this is what you do. And so in 2015, we pulled all our data from several centers, including Juanita Crooks in Kiruna, and out of 131 patients that were evaluable, we found that the local recurrence rate at 5 years was 1.5% for just a single day procedure. Telangiectasia, we find 21%, and this is telangiectasia. Like barely detectable, but me, I detect them, so I noted them. Vicini reported 30% with external beam radiation, so we are good. The only side effect was induration. In general, if you examine a patient 1 out of 5, you will find a little induration. Here you double. Skin pigmentation 10%, so very terrible. So at the end of the day, the word of caution is when, if a patient has to take 5 years of tamoxifen and you're sure they will observe that, you could question not giving radiation. But unless you're absolutely sure, don't let anyone guide you, tell you you don't need a radiation treatment for those patients. Because really, do you want 5 years of treatment that costs $22,000 versus a 5-hour treatment that could $2,000 or maybe $4,000 maximum? I think this is a choice that you should explain to the patient. So in my conclusion, I would say that treatment de-escalation, in my view, is not an absence of treatment, but it is to start to think, how can we deliver our radiation in such a manner that I will lower the burden on my patients? And just the image, Zahid, I'm sure you can appreciate this picture. It's more beautiful than Versailles. Right? Thank you.